Hi guys, I will be starting the session in like 2 to 3 minutes. Ask everybody to join in. We will be beginning the session in 2 minutes. All right, guys, I'm beginning the session. All right. Okay, I'm sharing my screen. Okay. All right. So the first question for today is the study subjects who are adherent to the regimen lose an average of 7 kg by the end of 10 weeks. Venous blood samples to study biochemical changes induced by weight loss are taken at the start of the trial and at the 10-week follow-up visit. Which of the following hormonal changes are likely to occur? So what's basically happened is that there are 50 obese adults and they were without diabetes mellitus. They were enrolled in a 10-week weight loss program. The program includes a low-calorie diet and moderate-intensity exercise for at least 150 minutes per week. The study subjects who are adherent to the regimen lose an average of 7 kg at the end of the 10 weeks. So what's happening?
Insulin will be reduced.
Okay, what else will happen?
I think leptin is the hunger one.
Leptin will be decreased, I think so.
Yeah, ghrelin will be high.
Okay,
And
all right.
ghrelin is a hunger hormone.
All right, okay. Anybody else?
Ghrelin will decrease and leptin will increase.
All right, okay. So ghrelin will decrease, leptin will increase. We know that ghrelin stimulates the appetite. What about leptin? What does leptin do? Yeah,
Signals
It's
satiety,
for
like
satiety.
feeling full. Yeah.
yeah, good job. Okay, so what will be the answer be?
A.
It will be
I
C.
think
No, it will be
A.
A.
It's A because ghrelin will increase
Ghrelin.
during hunger, leptin will decrease along with insulin.
Exactly. So ghrelin, we know in first aid it was already mentioned grrr, so that means that it stimulates appetite. Whereas leptin, we know that leptin, is during fasting states, leptin levels fall. What basically happens is that it decreases the appetite. So ghrelin is, kind of stimulating the appetite. It promotes weight gain, whereas leptin, it decreases the appetite. We know what insulin does. What does insulin do? Can anybody tell me? Anybody? The role of insulin in the body?
It increases during hyperglycemia.
Very good. So what it does is that it lowers body level glucose. So what happens when you put a patient on calorie restriction? First of all, there's increased ghrelin when you calorie restrict. Of course, you're not giving normal calories to the patient, so the appetite stimulating hormone, what will happen, it will become increased, all right, because you're calorie reducing, and as a result there will be decreased insulin and leptin level. Why? Because leptin works opposite of the ghrelin, and insulin, it lowers down the body glucose. If you do not have enough glucose in the body because of caloric restriction, then of course there will be decreased insulin levels. Same with leptin, because it functions vice versa to ghrelin, and that is why there will be increased ghrelin, decreased leptin, and decreased insulin. All right. Next question. Physical examination reveals a hypoplastic mandible, low set ears, bifid uvula, and cleft palate. A CXR reveals decreased soft tissue attenuation in the right anterior mediastinum. These findings most likely suggest impaired development of what of the following. All right, what's happening? What are these examination findings more suggestive of?
This
The
is
George
the
syndrome.
George syndrome.
Very good, George. Very good.
Also, we have this Trosse sign. So unusual flexion of the lateral wrist and thumb and extension of the fingers are observed with cuff blood pressure measurement. So that is a sign of hypocalcemia, and this is called Trosse sign. Okay, so hypocalcemia happens in the George syndrome because of the parathyroid gland is not formed there. And that is due to a third and fourth pharyngeal pouch that is not formed. So choice E is the right answer.
Very good. Yeah. So remember when I told you guys that the pharyngeal arches, pharyngeal pouches, and the clefts are very high yield, because they ask you about that, about like which arch, which pouch forms what structures. Okay. So this is very high yield. We know the third and fourth pharyngeal pouches, they form the parathyroid gland. There is 22q1112 11.2 microdeletion. If you remember, that also happens in like tetralogy of Fallot. It's sometimes linked to tetralogy of Fallot as well. If you remember, there was this 22q11.2 microdeletion in that. Because there is absence of parathyroid gland, the patient has hypocalcemia, and hypocalcemia causes tetany. So this twitching is, kind of reflective of tetany that's happening. This is, called the Shavastic sign and the Trousseau sign. So the twitching is known as the Shavastic sign, and when you inflate the blood pressure cuff, what it happens is that there's carpal spasm occurring. That is called as a Trousseau sign. Normally, there is thymic shadow that's visible on the newborn X-ray. If there is thymic hypoplasia happening, then you see decreased soft tissue attenuation. If there is thymus hypoplasia, then what that means that there's also T cell dysfunction, right? And if there is T cell dysfunction, then these patients are at an increased risk of viral, fungal, and protozoan infection. So what is happening? You see that there are co-truncal cardiac anomalies happening. So three things are happening in the George syndrome: very high yield. You will see heart abnormalities. Along with that, you will see hypocalcemia. You will also see repeated infections because of thymic hypoplasia. All right. Aside of that, all these microagnetia, short palpebral fissures, they're very genetic. But cleft palate is also very high yield in terms of clinical presentation. They love to kind of help you differentiate DiGeorge with other syndromes on the basis of cleft palate as well. So this is very high yield presentation. All right. And if you kind of go down, exactly that's what they talked about, that there is lack of parathyroid, there's thymic hypoplasia occurring over here. That is why you have hypocalcemia, T cell deficiency. Another important thing is the cleft palate that is also occurring with these conditions. All right, next question. So what's happening that there is so there's this patient who underwent total thyroidectomy, all right, by this radioactive iodine ablation. Okay, after surgery, she was prescribed pyroxene. Over the past 4 months, she has a weight loss despite having normal appetite. She feels sweaty. Blood pressure is a little high. Pulse is a little high. There's hand tremor and sweaty palms. Thyroid function test will likely reveal what? Yeah.
Increase T4, increase T3, decrease TSH.
All right. So what do you think the answer will be?
This,
Yeah, I think
this choice
B.
A because
I think
here
according
we
to
have
general rule, there will be the T3, T4 would be increased and the TSH would be decreased because it's like a picture of hyperthyroidism. But I
Yeah.
think this question will be more tricky than that. They won't give the question so plain and simple.
So, first of
Very
all, the patient is taking
A or B?
First of all, the patient is taking levothyroxine after their thyroidectomy, and they started having hyperthyroidism. So it definitely refers to thyroxicosis, and that would be like levothyroxine would decrease TSH, and it would increase T4, and as T4 is increased, T3 would also elevate. So it's F.
All right. We all agree with her?
A is most.
It will be A because
Be
the
A.
there is thyrotoxicosis. All the
I mean
symptoms are
E,
in the
it
shape
would
of
be E.
thyrotoxicosis. So the patient is taking levothyroxine that is increasing the thyroid levels. So T3, T4 will be increased.
Yes, it will be
If
E.
they are taking exogenous levels, T4 will be increased, and there will be peripheral conversion of the T4 to T3, and then the T3 level will also be increased there, and the TSH will be suppressed. So it will be A.
Actually, it's going to be A because TSH is low, T4 is high, and T3 is as well as high.
All right. So it's A.
Yes, doctor.
All right. Okay. Okay. Yeah. So what's happening is that when the patient is taking thyroxine, the patient there is, a possibility that if you do not do medical reconciliation for a patient, then what happens is that, sometimes they do not know what is the accurate dose of it, and sometimes that causes a problem in them overtaking a particular medication. And by overtaking thyroxine, you can get exogenous thyrotoxicosis, and that means that the thyroxine hormone is coming into the body by any external um, way. Again, what's happening is that there will be elevated T3 and thyroxine levels. So if you see over here that the triiodothyronine and thyroxine, they both will be increased because levothyroxine has an impact on both. And as a result, the TSH will be decreased. All right. You will also see low serum thyroglobulin. There will be low radioiodine uptake. Okay. In what other condition you will see a low radioiodine uptake? Anybody?
Post-viral thyroiditis, there is also low radiation in case of inflammation.
Okay. What else? So any condition having itis, like postpartum thyroiditis, there's also dequervin thyroiditis. Any itis condition of the thyroid gland will cause a low radioiodine uptake. All right, so that's also a great differentiation in between what is actually causing a low radioiodine uptake. All right, next question. Serum beta HCG is markedly elevated in serum TSH is normal. Scrotal ultrasound reveals a 3.1 centimeter irregular testicular mass with a cystic area, which is the following is most likely cause of the patient's gynecomastia. So there is this man who comes to the office for evaluation of an enlarged left testis. He reports decreased libido or erectile potency for the last 2 months. The patient has no chronic medical condition. Physical examination is notable for enlargement of the left testis and bilateral gynecomastia. All right, what's happening is beta HCG is elevated, TSH is normal. What is happening? What type of tumor is it?
The germ cell tumor
Testicular.
because it's creating beta HCG.
All right, so what will be the answer?
It's a testicular tumor, so it's D.
D, because of excessive testosterone, they are going to estrogen, by aerotominase activity.
Yes.
Very good.
Answer will-
Again, Again, we know that why is gynecomastia occurring because of increased beta HCG. We know that HCG secreting tumors are germ cell tumors. And what is happening is that excessive secretion of HCG will suppress the testosterone production, right? And when there's suppressed testosterone production, as a result, you will see that what's happening is that there's increased aromatase activity and there's conversion of testo to estradiol. So what basically is happening is that because of a rise in beta HCG, there will be a decline in testosterone, and that is also kind of triggering gynecomastia. It can also trigger infertility, sometimes permanently if the tumor is not removed. Again, if you kind of go up, these are really high yield resources for gynecomastia. Usually they like you to test on certain testicular tumors, and sometimes there are certain medications that can cause it. Physiological gynecomastia, sometimes they ask you, but not really. But usually they like to ask you in terms of testicular tumors, medication, cirrhosis, or sometimes hypogonadism. The other cause may be, a genetic cause such as in Klinefelter. You also see gynecomastia. So there was this question on NVMe that they love to ask, and they go like, oh, there's a 14-year-old boy, and he's being taunted in the gym room because of his breast development. He is a little fat, so is it actually gynecomastia or not? And the answer usually is that it's not gynecomastia, because in obese patients, you usually see a certain sort of breast tissue. That does not necessarily mean that they are undergoing gynecomastia. So the number one thing you advise to that patient is weight loss. And they love to ask that in terms of men. All right, so that was one thing that I wanted to say. Next question. During testicular examination, he is found to have a single testis in the scrotum. Laboratory evaluation shows an elevated FSH, and normal serum LH. Production of which of the following is most likely decreased in this patient? All right, what's happening? Very easy physiology question.
Yes,
Testosterone.
D here, inhibin B, because of the negative feedback of FSH.
Yeah, very good. So again, very, very easy question in terms of that. So this is the hypothalamus, this is the GnRH, this is anterior pituitary, posterior pituitary. We know that, it kind of secretes FSH, it also secretes LH. What basically happens is that FSH, it causes a negative inhibition through inhibin B, and that kind of has a negative effect over here. What about LH? How does LH get inhibited?
As LH is there is normal, and is regulated by the testosterone level.
Very
Which is
good.
inhibited by testosterone.
Very good. So testosterone has a negative feedback effect on both LH and GnRH secretion, while inhibin B suppresses FSH. So inhibin B is very specific for FSH, whereas LH and GnRH is negatively inhibited by testosterone. If you remember that, in undescended testicles, like in cryptocardism, we said that the patient is at an increased risk of cancer. They're at an increased risk of seminoma, right? Why? Because Sertoli cells are temperature sensitive, and if they are not in the right position, then they're prone to atrophy from heat damage. And that is why not only atrophy is the main cause, but in patients who have cryptocardism, they are at an increased risk of having cancer. So cancer and infertility are two of the high yield things that can happen, but they love to ask you in terms of cancer, and that is a seminoma. And so you're always scared about a seminoma in cryptocardism patients. And that is why surgery, arthropexy, is usually advised after the age of 6 months. All right. Okay. Next question. The patient's parents and siblings have no history of significant health problems. All right. He's at the 70th percentile. Oropharyngeal examination reveals a large red green gold mass. The patient subsequently undergoes excision of the mass. Histopathological preparation of the recovered tissue is shown below. Okay, so what's basically happening? There is this boy who's had difficulty breathing, hoarseness, and dysphagia, and the symptoms began like 6 months ago, but they have been worse for the past 4 weeks. The patient has nothing. He does not have any skin rash, pharyngeal pain, fever, weight loss. Okay, he's up to date on vaccination, so no problem. Failure of which of the following embryological process is most likely responsible for the patient's lesion? So what's going on here?
D. This the follicle tissues of the thyroid, and there is lingual thyroid. It's failure to migration to the neck.
Yeah. So what's basically happening is that there is, so if you kind of go through this, you will see that this is a sublingual thyroid, this is a foramen cecum, lingual thyroid, and that's kind of, they're telling you about how basically the thyroid descends to its normal location. This is a thyroglossal duct. So what basically happens is that when the patient's pathological specimen shows that there are normal thyroid follicles, and so this is basically the colloid. If you see this light pink color, it's colloid. It's consistent with lingual thyroid. So we know how the thyroid migrates into the middle of the neck, how it migrates through the thyroglossal duct. If there is failure of migration, then there is a lingual thyroid. How will you differentiate, this on a clinical exam? Can anybody tell me how can you find out if it's a lingual thyroid?
Lingual thyroid now clinically,
It
my
it will be
examination means
position.
they will,
The thyroid will be absent in its normal position clinically. So, and then on the ultrasound or the on the CT scan, we find it will be ectopic in a lingual position, and
Okay.
it will present as signs of hypothyroidism. Clinically present with hypothyroid.
So basically, what happens is you ask the patient to protrude their tongue. And when the patient is protruding the tongue, any lingual thyroid mass will become more prominent and visible. That can help you differentiate from other neck masses such as thyroglossal cyst or any enlarged lymph nodes, because lingual thyroid masses do not move with protrusion of the tongue. All right. So that is a most important clinical examination. When you ask the patient if that patient is suspicious for lingual thyroid, then you ask the patient to protrude their tongue, and if you see if the mass has moved, then that means it's lingual thyroid. All right. Any other masses, any other neck masses, including thyroglossal cyst or even lymph nodes, hyperplasia, whatever any neck masses, they do not move with tongue protrusion. So that's a very key differentiation. All right. Okay. Yeah. So, right, next question. Okay. Laboratory evaluation reveals normal hemoglobin, serum calcium, creatinine, and okay, so everything is normal. TSH is undetectable. X-ray reveals a compression fracture because of diffuse demineralization of the bone. Which of the following is most likely responsible for the bone abnormalities in the patient? So there is this woman who is there because of acute mid-thoracic back pain that started after a ground level fall. The patient also had weakness and weight loss for the past 2 months. All right, so their blood pressure is high, pulse is elevated, there's sweaty palms, fine hand tremor. Very easy question. What's happening?
this is a case of hyperthyroidism,
Okay.
and
Why is the
the
TSH
thyroid, yes,
undetectable?
is directly stimulate the osteoclast, and that's why I think D, increased bone resorption due to stimulation of the osteoclast.
Okay, so what do you think the answer will be?
D, ma'am.
D. All right, okay. So again, we are talking about that the patient has hyperthyroidism. Hyperthyroidism causes everything to be increased. So high blood pressure, high pulse rate, patient will be sweaty, increased demineralization of the bones, and that is why the patient was having osteoporosis over here. Again, hyperthyroidism can cause increased bone turnover with the net bone loss. So when I said that the bone loss, it's driven by triiodothyronine, which stimulates osteoclast differentiation, increased bone resorption, and release of the calcium. And that is why you see that the TSH is undetectable over here, because it is kind of regulated by triiodothyronine. So if you kind of see it over here, so T3 has an effect on osteoclast activation that causes bone resorption. So when the bone is resorbed, then there's calcium release. As a result, PTH goes down due to negative feedback, and it decreases 125 dihydroxyvitamin D. And when it decreases intestinal calcium absorption, and then that also kind of triggers bone resorption. So it's a cycle that continues over here. All right. Okay. Next question. When asked, he admits to using a performance-enhancing substance for the past 6 months. Okay, so there is this boy who's been evaluated for irritability, slow growth, and acne. The patient is playing soccer. What is he using?
Steroids.
Testosterone steroids. Used for
Steroids.
the gain of muscular mass.
Very good. Steroids. What does steroids do?
It decreases the spermatogenesis.
All right. What about estrogen and LH?
And testosterone then is decreased LH. And by negative feedback, also decrease in thalamus the gonadotropic releasing hormone, decrease the follicle stimulating hormone also.
All right. So the answer is what?
E, because spermatogenesis is also inhibited, and the LH will also be decreased because taking exogenous.
Yes, E ma'am, because of estrogen is converted from due to erotomies, testosterone converted to the estrogen. Estrogen high, otherwise both low. Yes.
Exactly. So we know that any exogenous steroids, they suppress DNRH, LH, and FSH, and that is why there is decreased testosterone secretion. There is also impaired spermatogenesis and testicular atrophy that is also occurring alongside with it. Not only that, it can also lead to gynecomastia. So why is it leading to gynecomastia? Because estrogen is increasing, right? So low spermatogenesis, high serum estrogen, and of course LH, we know that it's triggered through testosterone. So testosterone will be automatically going down. So that is why LH is low, estrogen is high. Why? Because gynecomastia can occur, and of course we know that spermatogenesis decreases, and that is why testicular atrophy can also occur. Because there's high level of estrogen, there's one thing I want you to be aware about: premature epiphyseal closure and short stature. This is very high yield in terms of step 1. They have been repeatedly testing on this. Why? Because they're increasing levels of estrogen. And it's interesting because if you see that most women are shorter than men. Why? Because the reason is that increased estrogen is causing premature epiphyseal closure, and that is why women have a shorter stature than 90% of the men. So this is the reason that's also happening in women. And if you kind of go down and you see this, that's what exactly they talk about. Again, physiology question, very easy. The cycle is really high yield. You need to be able to differentiate what every hormone does. How is it getting negatively inhibited? What is its effect? So these are the important combinations that you need to remember in terms of step 1. All right. Next question. During the pregnancy, the mother took acetaminophen intermittently for a low back pain. Examination of the newborn shows some normal findings. Repeat thyroid function tests are as follows. This is free T4. So T4 is normal. Total T4 This is total T4. This is TSH. Which of the following is most likely cause of patients of normal thyroid function test? So basically, there is this 1-week-old newborn for abnormal thyroid function test. The thyroxine was low and serum TSH was normal. The patient was born at an SPT at 40 weeks of gestation, 228-year-old primigravida. Okay, what's happening? What did acetaminophen do?
Genesis.
Yes, B deficiency binding, thyroxine binding globally.
Exactly. So there are some medications that increase TBG and decrease TBG, right? So if there's decrease in TBG and that is why there are the labs, what are some of the things that increase TBG? Can anybody tell me?
Pregnancy.
Pregnancy and OCP.
Pregnancy, very
Oral
good.
contraceptive pills.
Oral
OCP use.
contraceptives, very good. What else? Increase in estrogen. Okay, what else?
Oral contraceptives.
Yeah, good. So this again we talked about that. So what's happening is that if you kind of increase the picture, you will see the decreased TBG. That means that there's decreased bound T4. If there's an increase in free T4, what it does is it negatively inhibits TRH, and as a result, it negatively inhibits anterior pituitary, and as a result, TSH is blocked. TSH is released. TSH further blocks thyroid, and there is negative release of the hormone. All right, so decreased total T4 available, that means free T4 level normalizes, that's a particular euthyroid state, and then as a result, TSH level normalized. So what happens is that if the neonate had a low total thyroxine level, but normal free T4 and normal TSH, which means that there is normal TSH, normal T4, and that there's low total thyroxine, and that means that there's some deficiency of thyroxine binding globulin. Congenital TBG deficiency is usually benign. But what happens is the majority, because we know that acetaminophen is cleared by the liver, and the majority of the circulating T4 is bound to the TBG, and that kind of happens where, so it serves as a storage pool to replenish the biologically active free T4 that is continuously cleared by the kidneys. So this is kind of hard to understand. I understand that. But just remember, for the purposes of that sometimes when this clinical vignette is being presented, the serum TSH is normal and the serum thyroxine is normal. Most of the time, there's a decrease in TBG. All right, they don't want you to know if it's a congenital cause or a medication-induced cause, but in order to be looking at the labs, you can differentiate that what's actually happening. All right, so if you don't understand this as well, so that's okay, but just try to remember this, that if it's normal, if both of them are normal, that means that there's some deficiency of TBG going on. They also love to ask you that what increases TBG, so that's pregnancy, OCPs, increase in estrogen, and yeah, that's pretty much about this question. All right, next question. The thyroid gland is tended to palpation and diffusely enlarged. It's sweaty palms, fine hand tremor. Okay, brisk GTRs. Laboratory studies show suppressed TSH and elevated free thyroxine levels. ESR is 7A. Which of the following additional findings is most likely to be, present in this patient? So I think I already told you guys is, what does this mean? What does ESR increase mean?
Inflammatory condition.
Inflammation. Inflammation means itis, right? So which means that there's some sort of itis going on. What did I tell you about itis?
Low radioactive iodine.
Yes, B. Yes.
B.
It will
That's
be.
what they told us.
As you told you, ma'am, any
Exactly.
inflammation, that it decrease the
Very
radioactivity.
good. Any
Any
itis
itis.
does not want to take iodine because it's already inflamed, right? And if you kind of go up and realize, okay, what's happening? History of neck pain, most likely they're referring to dequervant thyroiditis, right? Upper respiratory infection, and then there's this neck pain. Okay, symptoms resolved. So basically they're referring to viral thyroiditis, right? That's what they're basically referring. Again, So it's also known as subacute or dequervin. Both of the things are okay. Again, you have painful tender thyroiditis. Most of the time, it's post-viral inflammatory response. Like I said, it can occur after any viral infection, and it's very painful. Again, initially you have a hyperthyroid phase, and then it kind of progresses to hypothyroid, and then it returns to euthyroid. What you need to remember for step one is that it has an elevated ESR. Why? Because it's an infection, and any sort of inflammation. What's happening is that there will be a low radioiodine uptake. All right. So you see subacute granulomatous dequervin thyroiditis. They love to use multiple names for this, but it usually is referring to one thing. In postpartum thyroiditis, you will also see a decrease in the iodine. What else? What other condition you will see a low radioactive iodine uptake?
Hashimoto thyroiditis.
Thyrotoxicosis.
What else? No?
If multinodular, if the nodules are cold nodules, then also there is decrease. What I think.
Congenital hypothyroidism.
Drug induced.
Okay, yeah. Iodine overload can also have that, right? Any sort of subacute thyroiditis, silent thyroiditis, postpartum thyroiditis can also have it. Iodine overload can have it. Sometimes amiodarone-induced hyperthyroidism, if you remember, amiodarone, we check the TFTs, PFTs, and the LFTs, right? So TFTs, it causes hypothyroidism, and over there you can see a low radioactive iodine uptake because amiodarone can also cause inflammatory thyroiditis. All right. Okay. Next question. All right. On physical examination, the thyroid is diffusely enlarged with no palpable nodules, no tracheal deviation. Okay. TSH, free thyroxine, normal. Antibodies against TPO are present in high titers. What does this mean? What does this mean?
Hashimoto thyroiditis.
Hashimoto's. Okay. All right, so she's having goiter. The neck has gotten significantly large. She's had no neck irradiation. She has a sister with vitiligo. Interesting, because I told you guys that autoimmune diseases go hand to hand. So if a patient is already having autoimmune diseases, you're more likely to develop autoimmune conditions later on in their life. All right, what do you think is the answer?
E.
E?
No, sorry.
C.
A.
It should be C.
Should be C. C.
Thyroid peroxidase has three functions: oxidation, organification, and coupling. Organification is this one, thyroglobulin iodination.
Yeah, very good. Again, this physiology is very, very high yield for you to kind of remember. Again, you should be aware of the TPO. It catalyzes the oxidation of iodide to iodine, and the iodination of thyroglyph. You see it over here. Wait, I'm gonna make it zoom over here. No, over here you won't understand anything, but okay. So over here, you see that this TPO, it catalyzes the oxidation of iodide to iodine, the iodination of the thyroglobulin, tyrosine residues, and the iodotyrosine coupling reaction that forms T3 and T4. Antibodies against TPO means that the patient is having chronic lymphocytic Hashimoto's thyroiditis. They also love to, kind of interchange the name Hashimoto with chronic lymphocytic thyroiditis. Mostly they're referring to Hashimoto's. So don't get confused on steps. They're most likely referring to Hashimoto's thyroiditis. Again, autoimmune, everything is going low, there's goiter present, antibodies against TPO means that there's a problem with thyroglobulin iodination. There will be no coupling reaction, and as a result, thyroxine will get deficient when it cannot get converted to its active form. All right. Okay. Next question. So there's CKD from diabetic nephropathy going on. GFR has, kind of decreased. He's in consideration for initiation of hemodialysis. Which of the following is most likely contributing to this patient's current glycemic disturbances? What is happening? That this patient has had diabetes and he's coming because of recurrent hypoglycemic episodes. He previously had difficulty controlling his high blood glucose, but intermittently the glucose levels are dropping. Okay, there's tremulousness and headache. There has been no changes. All right, what's happening?
This may be yesterday, Dr. Boaz, he explained, when there is long-term diabetes mellitus, it affects the renal, means the insulin is metabolized in the liver and the renal. And in case of CKD, chronic disease, the insulin is not excreted and glucose is excreted. That's why it can cause episode of hypoglycemia.
Yes. Correct. Yes.
Yeah. So we know that insulin is a peptide hormone that is secreted from the kidney and the liver. And we know that, degradation of circulating insulin, it is dependent upon the GFR, all right, which allows for the delivery of the insulin to the PCD where it's kind of broken down. If there's CKD going on, then the patient will have decreased GFR that will impair insulin clearance. And when the insulin clearance is impaired, as a result, what is happening is that the patient will be at a risk of hypoglycemia. The insulin clearance is decreased. As a result, there will be more insulin circulating in the blood, and the patient will be at a risk of hypoglycemia. So you see that there's CKD going on, symptomatic hypoglycemia. It is due to reduced renal clearance that is prolonging the insulin effect. And as a result, the patient is experiencing symptomatic hypoglycemia. So what the treatment is that the insulin is usually then adjusted in response to the GFR. If the GFR is decreasing drastically, then you need to adjust the insulin doses along with the kidney and liver functions. All right. Okay. Next question. So what's happening is that LH and FSH are monitored in the initial phase of treatment, which of the following is most likely indicational for using the GnRH infusion. So there's this patient who's treated with GnRH infusion. An IV line is placed and connected to a reservoir through a computerized pump. The pump is programmed to deliver predetermined dose of GnRH every 90 minutes, which results in a sharp rise in GnRH with each dose, followed by a rapid return to the baseline. Why? So is GnRH given in a pulsatile fashion over here or not?
If given pulsatile, increase the FSH and LH. If giving continuously, it will give means decrease the LH and FSH due to negative feedback.
Okay. So what is the answer?
It's infertility.
Yes, C, infertility.
All right. Yeah, very good. So we know that GnRH was given in the pulsatile fashion over here because it was given after every 90 minutes. So if you give pulsatile GnRH, what it does is that, it causes enhanced FSH and LH secretion. And we know that, both are kind of given in response to an ovulation, which is a common form of infertility. If you give it in a pulsatile fashion, then what's going to happen? Sorry, if you don't give it in a pulsatile fashion, if you give it in a continuous fashion, then what's going to happen? It will cause
downward decrease by negative feedback by gonadotropin releasing hormone, and then it's by yes.
It will suppress the LH and FSH secretion, right? That's what it's going to happen. And so that is usually given in conditions like endometriosis, precocious puberty. Leuprolide is something that's tested in the form of a drug in terms of reproduction chapter. They love to test leuprolide in terms of precocious puberty. All right, so leuprolide for precocious puberty. Why? Because it's a constant. So GnRH is given in a constant manner, and it's one of the long-acting GnRH analog, and leuprolide because it kind of lowers the LH and FSH, and that is why it's kind of given in precocious or early puberty, so that the puberty gets delayed. All right. Okay, it's also given in endometriosis, but they love to test you leuprolide in terms of precocious puberty. All right. Okay.
Yes, ma'am.
Next.
And there is one question also, leuprolide, that initially it will stimulate, it will increase the FSS short acting. And then, there is one more question in your word I have already seen.
You're right. So initially leuprolide will increase, but if you give it a continuously, then long, because see, it's very long acting GnRH analog. So what it does, and so the name itself suggests that it's going to take a little bit of time to bring down those hormones, right? So initially it's going to increase, and on a longer, if you give it continuously again and again, so what's going to happen? It's going to decrease into the long term. All right. So I think they give you a graph on step 1 where they say that, oh, this is happening, and children usually just go and pick up, oh, so basically leuprolide is decreasing LH and FSH, and that's usually the wrong answer in step 1. So initially it's gonna increase, and long term it's gonna decrease. All right. Okay. Next question. So what's happening? Okay, at CXR reveals right lower lobe pneumonia, and treatment is started with supplemental oxygen antibiotics. All right, develops persistent sinus tachy. Thyroid function tests are ordered. Okay, so TSH is normal. Free thyroxine is also normal. T3 total is low. Okay, which of the following is a primary contributor? What's happening? Why is the T3 low?
I think it would be A, because the peripheral tissue conversion of T4 to T3 is decreased by taking some drugs or things that can basically decrease the peripheral conversion.
Okay.
Yes. Yeah, I agree also. Yeah.
So there is
Because
this
T4 is okay.
euthyroid 6 syndrome that I want you to be aware of. That euthyroid 6 syndrome, what it does is the high yield lab they test you is low RT3. All right. So it decreases RT3. Now, what do you mean by RT3? Can anybody tell me? Is it different from the normal T3?
That would be the reverse.
Yes.
The reverse
T3
T3
is
an inactive product. That is a byproduct and an inactive product produced from the T4, and it's basically increased by taking drugs like steroids or something, glucocorticoids. So then it's an inactive product.
Okay, so is it gonna increase in euthyroid 6 sinus or decrease? Is the RT3 gonna be increased or decreased in euthyroid 6 syndrome?
I think is the reverse.
Increase.
Will increase.
Increase, yes. So
Increase, yeah.
what's happening is that the low euthyroid in euthyroid 6 syndrome, it can occur in any condition. All right. So if you are too sick, it can occur in ICU patients. It can occur if you have chronic pneumonia infections. So it basically occurs in hospitalized or sick people. What is basically happening is that there is low T3 that's occurring, and rest of the labs will be normal, and RT3 reverse thyroidine will be increased. All right, RT3, they love to test you on RT3 as well, so RT3 will be increased and there will be low T3. Okay, there is no treatment for euthyroid 6 syndrome except to treat the cause. Okay, just treat the cause of it. There is no specific treatment. You don't have to worry about the thyroid labs going on. Just remember that the T3 will be low and RT3 will be increased. That is kind of a finding for euthyroid 6 syndrome. In what patients is it occurring? It's occurring in sick patients, and ICU patients, people who are hospitalized. Okay. Why is it occurring? Because in severely ill patients there is high level of cortisol. So we know that cortisol is basically a stress hormone, right? We're aware of that. So in any conditions of stress, when the body is in a lot of stress or it's undergoing in any sort of illness, the cortisol levels will increase, inflammatory cytokines will increase, and free fatty acids, they will suppress the deiodination of T4. And when there is suppress in the deiodination of T4, that will cause lower circulating levels of T3. Okay, and if you kind of see it over here, that will kind of increase conversion of T4 to reverse T3 in the inactive form, and that is why you see an increase in the RT3. Okay, so RT3 is increased, T3 is low. All right, don't treat it, just treat the cause of it. Okay. All right, next question. The thyroid gland is diffusely enlarged palpation without tenderness or bruit. Okay, there are no focal findings. Triiodothyronin, it is, high. Which of the following is most likely to challenge the patient's thyroid function test abnormality? So the patient is well, fidgety, impulsive, inattentive, restless. Okay, decline is great. What is this condition called?
Cretinism?
ADHD. Inattentive, impulsive.
Thyrotoxicosis?
Okay, so in this patient, we have TSH is high because it is 0.4 to 4, so TSH is high. Thyroxine level is also high. 3-iodothyronine levels are also high. So everything is high here. But the thing is that the thyroid hormone is not doing its function, okay? So the answer should be resistance to the thyroid hormone. So the thyroid hormones are there, but they are not binding or doing the function on the receptor. So it is providing a positive feedback. That's why you have increased TSH and increased thyroxine levels and also T3. So the answer should be E, resistance to thyroid hormone. And when you have when the function of the thyroid hormone does not work, that's why you have like cognitive functions such as ADHD.
Yeah, you're right. So what is basically happening is that this patient has ADHD, all right? If you see that there's fidgety, impulsive, inattentive, restless, progressive decline in the grades, most likely they're referring to ADHD, all right? Now, the thing about over here that if you see that there's increased levels of thyroxine, triiodothyronin, and TSH, they are concerning for thyroid hormone resistance. If everything is high, then that means there's some sort of resistance going on. Why? Because there's any inherited mutation that's affecting the thyroid hormone receptor beta, which results in decreased thyroid hormone sensitivity. What I want you to remember in terms of this is just this educational objective, that if you kind of try to remember this, so those patients who have thyroid hormone resistance, they develop ADHD as well. So ADHD is kind of linked together with thyroid hormone resistance. Those patients typically also have goiter, and so how can you differentiate the thyroid hormone resistance? Everything will be high, all right. And that can cause you to kind of help differentiate that with thyroid hormone resistance or any other condition that's going on. Just try to remember that thyroid hormone resistance sometimes can also occur in patients who have ADHD, and they kind of go hand in hand together because of similar presentation. All right. Sometimes these patients have goiter as well. Some people take goiter as a sign of hypothyroidism, but goiter can also occur in hyperthyroidism. It can also occur in hypothyroidism, so it can occur in both conditions. It is not specific for just hypothyroidism. Okay. All right. Next question. Ultrasound on the neck reveals an ectopically located small thyroid gland just above the thyroid bone. Early treatment with levothyroxine is indicated to primarily prevent which of the following? What is this thing called? Can anybody? Okay, ectopic thyroid. Okay, why are we treating it with thyroxine? To prevent what?
Hypothyroidism. Prevent hypothyroidism.
To prevent neurocognitive dysfunction. That's primarily to prevent that.
Yeah, You're right. So what is happening if the patient is having hypothyroidism? We know the thyroid hormone, it also helps, with the neurocognitive problems. And then if you kind of see it over here, that a boy or a baby, who's having hypothyroidism will have, protruding tongue, puffy face, umbilical hernia, very, very, high yield for USMLE, constipation, all of it. And that is why newborn screenings are done for congenital hypothyroidism. They're also done for hypoglycemia. They're also done for any metabolic disorders. So those are the three things that you do newborn screenings for. And if you kind of see this over here, so neurocognitive dysfunction is a very, very, adverse effect of hypothyroidism that's occurring. Those patients will be severely neurocompromised if you don't treat them with thyroid hormone in their early stages of life. If you kind of go down and see, that's what they're talking about. Similar thing. All of those things are not, they're not like fatal to the patient. So if you see that primarily to prevent it, that means that's the utmost thing that we need to prevent, that we cannot reverse, right? Excessive weight gain, we can reverse. Nutrient malabsorption, we can change. Thyroid gland enlargement, okay, still slight possibility. Proptosis, no, it's not life threatening. But if there's neurocognitive dysfunction going on, then it is life threatening in terms of future progression. All right. Okay, last question for today, guys. Laboratory results shows normal serum electrolytes and renal function. CAT scan, the abdomen reveals a mass in the right adrenal gland. Which of the following cells have the same embryological origin as the tissue responsible for the patient's condition? All right, so BP is really high. There is this man who comes to the office with several months of episodic headaches, okay? Sweating, feelings of anxiety that spontaneously resolve after 15-30 minutes. His brother recently had surgery to treat hyperparathyroidism. What's going on?
Pheochromocytoma,
Pheochromocytoma.
And D.
melanin producing cells.
Neural crest cells. No, it will be D. The melanoma, melanoma is also arise from the neural crest cells. So that.
Okay, what does thyroid follicular cells produce? What hormone?
T3, T4.
Okay. What about thyroid medullary cells?
These are non-epinephrine, both. 80% epinephrine. Calcitonin from parafollicular thyroid cells.
Very good. So again, they're referring to a pheochromocytoma. So pheochromocytoma, it presents with episodic hypertension, and it can also present with episodic headache. That can be a cause of hypertension. The other things that you need to be aware of, the pheochromocytoma is associated with men type 2. So this is something that you need to be aware of. Men type 2A and 2B both have pheochromocytoma, against the tumor arising from adrenal medulla. It's a catecholamine secreting tumor. Another thing is that the adrenal medulla cells, are the chromaffin cells, and they are also derived from the neural crest cells. Again, neural crest cells are also melanocytes. They're melanin producing cells and neural ganglia. They don't ask you about the cardiac and the skeletal structures that are derived from the neural crest cells, but they are really, really invested in you knowing that melanin producing cells are arised from the neural crest cells. If you kind of go down, I think I helped you mark what's important in terms of this, and if not, then I can go again. So for ectoderm, they love to ask about inferior pituitary. They love to ask about the epidermis, and mammary glands. They love to ask about the nasal and oral epithelial linings. For neural tube, that's very easy. Wing spinal cord, posterior pituitary pineal gland. For neural crest, they love to ask you about melanocytes. They love to ask you about Schwann cells, PN arachnoid matter. They love to ask you about neural ganglia, adrenal medulla. Sometimes they ask you about pulmonary septum. Not always, but sometimes. All right. For mesoderm, they love to ask you about muscles, connective tissue, cardiovascular. They love to ask you about spleen. They love to ask you about kidney, adrenal cortex. For endoderm, they ask you about lungs, thymus, parathyroid, and third follicular cells, very high yield. They ask you about parafollicular cells, and that's it. Sometimes pancreas, but not usually. So these are the things that I highlighted over here. They love to ask you about that on USMLE. You kind of go down. That's it. How do you treat pheochromocytoma? Anyone?
It may be surgery. First, they optimize the function, means the blood pressure, starting first the alpha blockers, and then they start combine with beta blocker. When blood pressure is okay, they do the 2 minutes ECG strap if there is no excess systole, and if this patient is orthostatic hypotensive, that means the medication is already effective. Then they go for surgery. It is removal of the tumor,
Okay,
pheochromocytoma.
so what do you give first, phenoxybenzamine or phentolamine? What do you give first?
Phenoxybenzamine.
Pyroxybenzamine.
Good.
Yeah, because it's which one is the long acting? Confusing which. They're giving the long acting, and during the surgery they give the short acting because in the after removal there is hypotensive. That's why in during perioperative time they give the short acting, but orally they give a long acting. Which one is phenoxybenzamine? I think
Yeah,
that
you're
is the
right.
oral. Yeah.
Very good. So you do the medical management first and then you excise the tumor. You do not first try to excise the tumor and then go for any medical management. Remember, it's always a step up approach. People, usually pick up the answer, which is more surgical and invasive. USMLE wants you to know that, if you can heal a patient without touching, then you are an angel in front of their eyes. So they don't want you to touch the patient unless it's very severe. Try to do that. Medical management is always the first line of management. Before medical management, you try conservative management. Of course, if the patient is coming to you, most of the times they aren't aware of what's going on and they come to you in their late stages of disease. So then you try to do the medical management, because conservative management then won't work, right? So you try with the medical management, then you go for the surgery. Never pick surgery first. That, okay, let's just remove the tumor. No, try to curb down the disease through medicine. And if still isn't working, then go for surgery. Okay. So I think Dr. Moaz is here. I will be taking the class from tomorrow. Happy learning, guys, and you guys can continue with Dr. Moaz.
Thank you.
Okay. Hello, everyone. I hope all of you are doing well. So, from today, we are going to start the pathology portion of endocrine, right? So, we're going to start the pathology portion of the endocrine system, right? And the first disease that we're going to do today is the SIADH, right? So, we have covered all the hormones, all the physiologies of the hormone, and now we are going to go into the detail of so now we are going to go into the details of these hormones in the pathology portion, right? So the first hormone that we are going to look at is the ADH hormone, right? And what is SIADH, right? So SIADH is very simple, right? So you have an excess of an antidiuretic hormone. That thing is known as the SIADH, right? So antidiuretic hormone can have two pathologies, right? So either there could be an excess of it, and that condition is known as the SIADH, or there could be an absence of it, right? And that condition is known as the diabetes insipidus, right? So we can either have an excess of this hormone, or we can have a negligence of this hormone, and that thing is known as the diabetes insipidus. So we're going to start from the SIADH, right? So what is the SIADH? So whenever there is a lot of antidiuretic hormone that is present in your system, what is going to happen is that you are going to go absorb a lot of water, right? So whenever you have a lot of ADH in your system, you're going to absorb a lot of water, right? When all of that water gets absorbed, right? So your volume of the your volume of the body is gonna be increased, right? So water volume in the body is gonna be increased, right? And as soon as the water volume of the body is gonna increase, right? Can someone tell me what are the structures? What will the heart secrete, and from what structure of the heart is the hormone gonna get secreted?
ANT
Okay.
and
Yes. So
ANC from
whenever
and
yes.
then treatment.
So whenever we have excess amount of volume, whenever we have excess amount of volume, ANP and BNP are gonna be released, right? ANP and BNP are going to be released from the heart, from the left ventricle, and then the main function of ANP and BNP is natriuresis, right? So it is going to excrete all of the sodium from the body, right? Because whenever you secrete sodium from the body, water is going to be excreted with it as well, right? So sodium excretion from the body is going to be increased, right? And what you are going to get is hyponatremia, right? So this is the whole mechanism by which SIADH works, right? And this is very important. They love to test this concept again and again. So why does so ADH hormone excess won't lead to increased amount of water in the body, right? In the end, there won't be increased amount of water. The main thing that will be present is euvolemic hyponatremia, right? Again, this is a very different concept, because whenever you look at ADH, you are going to think that the person is going to have hypervolemia now, right? The patient is going to have increased amount of water in the system, but that is not true. The patient is not going to have an increased amount of water in the system. The water in the system is going to be normal. Why? Because ANP and BNP are going to come into the question, and they're going to decrease the amount of water, but as a side effect, they are going to increase the amount of sodium as well. So you are going to get hyponatremia, right? At the same time, and so we have another hormone, that is the aldosterone, right? So aldosterone also increases the secretion, also increases the absorption of sodium. But now aldosterone is going to decrease as well. And as soon as the aldosterone decreases, you are going to get decreased amount of water, decreased amount of sodium in the body, right? You are going to get decreased amount of sodium in the body, right? This is very important. Keep this thing in mind, that there is hyponatremia in SIADH, right? Now the second thing is that whenever there would be SIADH, the urinary sodium is going to be increased, right? Why? Because ANP and BNP increase the amount of urinary sodium. Right? That is the first thing. And remember, all of these, so the normal plasma osmolality is 285 to 295, right? So the normal plasma osmolality is 285 to 295 milliosmol per liter. And all of this is made by the sodium, right? So all of this is made by the sodium. So if sodium is decreasing in the body, the plasma osmolality is going to decrease below 285. So it's going to be 260 or 275. So if USMLEs give you a question and they say that urine is having greater osmolality, right, and the serum osmolality is reduced, right? Again, if the urine osmolality is increased, and the urine osmolality is going to increase due to sodium, and the serum osmolality is decreased, right? And the patient is having euvolemic hyponatremia, what is the most likely cause? The most likely cause is going to be SIADH, right? So it's going to be the syndrome of inappropriate antidiuretic hormone secretion. Now there are a lot of causes for SIADH, right? There are a lot of causes for SIADH. So what are those causes, right? So what things can cause SIADH? The number one thing that comes into my mind is a trauma, right? So whenever a patient is having head trauma, so whenever a patient of RTA, or whenever a patient of any head trauma or subarachnoid hemorrhage or any kind of hemorrhage comes to you, that patient is going to have hyponatremia, and then they are going to ask you, why is this patient having hyponatremia, right? And then they can ask you, what is the pathophysiology, or what hormones are playing an important role in the pathophysiology of this condition. So the main hormones that are going to play an important role are going to be ANP and BNP along with aldosterone, right? So aldosterone, ANP, aldosterone is going to decrease, ANP and BNP are going to increase, right? Second thing is that sometimes there is ectopic secretion of ADH, right? Sometimes not the pituitary, instead of the pituitary, right? The lungs are going to secrete ADH. And when is this going to happen? When the patient is having small cell lung cancer. When the patient is going to have small cell lung cancer, right? So how could they give you this question in the exam? So now they could give you a question that a 65-year-old male comes to you, and that male has been smoking cigarettes for the last 40 years, and he has a pack history of 45 years, right? So a patient comes to you, that patient is having pack history of 45 years, right? And now that patient comes to you, and that patient is having acute confusion, that patient is having nausea, that patient is having fatigue as well, right? Remember, all of these are the symptoms of SIAD. All of the symptoms are the hyponatremia, right? And then they're going to say you, we check the serum osmolality. Now they could give you two questions here. First of all, they could ask you what would be the serum osmolality, right? And then they would say that we did an X-ray, and the X-ray shows a lung nodule, right, or a lung cancer. And then they could ask you, what is the serum osmolality, what is the urine osmolality, right? And what is the amount of urine in the sodium, is it increased, did it decrease, and what's the amount of hormones in the body, right? And then there could be the ticks, up and down ticks, right? So aldosterone is going to decrease, ANP and BNP are going to increase, ADH is going to increase as well, right? So this is how they test you. They give you different questions on these things. Now another thing is that whenever a patient is being treated for depression, so whenever a patient is being treated for depression, the patient is taking SSRIs, the patient again can have SIADH, right? At the same time, we have a hormone which we have a drug which is known as the carbamazepine, right? Which is taken for seizure disorders, right? So again, if they give you a question that a person comes to you and that person was being treated for seizure disorder, but now his electrolytes are out of whack, right? His electrolytes are out of whack, and what is the most likely cause for it? The most likely cause for it is again gonna be SIADH, right? So this is how SIADH presents in the exams for you, right? So any question till this pathology? If not, we are gonna move forward. Okay. Okay. Now the next thing that we're gonna study is the diabetes insipidus, right? So what is diabetes insipidus? So diabetes insipidus means that the ADH in the body is not present, or if it is present, it cannot act on the receptors. The receptors are resistant to it, right? The receptors are resistant to it. So now what is going to happen is that no more water is going to be absorbed in the collecting duct and at the distal convoluted tubule, right? No more water is going to be no more water is going to be absorbed at these parts, right? So you're going to have an increased amount of urine, and that urine is going to be dilute, right? So you're going to have an increased amount of water, and that water is not going to have any sodium in it, right? So sodium levels are going to be decreased. You're going to have decreased amount of sodium levels. The serum osmolality is going to be increased. So it's going to be the reverse. So serum osmolality is going to be increased, and you're going to have increased amount of thirst, right? So urine osmolality is going to be decreased, and urine osmolality is going to be decreased. The serum osmolality is going to be increased as well, right? So now we have two types of um, um diabetes insipidus. One is the central diabetes insipidus, right, which happens due to low amount of ADH release. So for example, you are having a brain injury, you had a trauma, you had hypoxia, you had a tumor, you had a surgery, and after that the pituitary part which secreted the ADH is not working anymore, right? So hypothalamus that secreted ADH and sent it to posterior pituitary is not working anymore, and then we have another type which is the nephrogenic diabetes insipidus. In case of nephrogenic diabetes insipidus, the receptors, especially the V2 receptors, remember, the V2 receptors are resistance, not the V1 receptors. Now, this is a question that they are going to ask you. So the V1 receptors are present on the blood vessels, right? And the V2 receptors are present in the collecting duct. And it is the V2 receptor that will have a mutation, and as a result, it won't work, right? The receptor won't work, ADH won't gonna be functioning, right? Now, some other things can cause these things as well, and what are those things? If a patient is taking lithium, right? So when does a patient take lithium? A patient takes lithium whenever the patient is having, so whenever a patient is having um what you can say, so if a patient is having a problem with the
Bipolar disorder.
bipolar disorder, yes. So whenever a patient is having a bipolar disorder, right, the patient would be taking, yes. So the patient would be taking lithium, right? So the patient would be taking lithium whenever the patient is having bipolar disorder, and that patient could have diabetes insipidus, right? So they could give you a patient that a patient comes to you and that patient is having increased amount of urine for the past 1 month. That patient has a psychiatric disorder, and for that patient he's taking lithium, right? For that condition he's taking lithium, and now all of a sudden his serum osmolality.
Dr. Moore,
Yes,
sorry for
yes.
interruption. Could you go a little bit slow because you are going so fast? I think I couldn't grab. Uh, if you, if possible,
Okay,
thank you.
okay, okay, okay. So I was saying that if a okay, so I was saying that imagine if a person, so what is diabetes insipidus? Diabetes insipidus means that the ADH is not working properly, right? The ADH is not working properly. So now there could be two reasons why this thing is happening. So the first reason is that the ADH is not being produced, right? So where is the ADH produced? The ADH is produced in the brain, in the hypothalamus, and then it goes to the posterior pituitary. So what happens is that sometimes there is a brain trauma, there is a brain surgery, right? There is a brain tumor, or there are some infiltrative diseases such as sarcoidosis or hemochromatosis, in which the hypothalamus is affected a lot. As a result, the body cannot secrete any more ADH, right? And now you are going to have a deficiency of ADH. So when you are going to have this deficiency of ADH, as a result, what is going to happen is that your body is not going to absorb any more water, right? All the water is going to go into the urine. And remember, whenever you have an excess of water anywhere, the osmolality of that place is going to be decreased, right? So if more water is present in the urine is going to have a decreased osmolality. And since so serum does not have, or your plasma does not have any more water, the plasma osmolality or the serum osmolality is going to be increased, right? So this is the first thing that you should know. And the ADH levels are going to be decreased as well, right? Now we have another thing which is known as the nephrogenic diabetes insipidus. Why is it called the nephrogenic diabetes insipidus? Because remember, the V2 receptors for ADH are only present in the nephrons, right? They're only present in the nephrons. They're not present anywhere on the body, and it is the V2 receptors that are going to have a problem in nephrogenic diabetes insipidus. Now, another important concept that comes here is that in case of nephrogenic diabetes insipidus, there is gonna be ADH resistance. So the body is gonna make more it, and the lab values are gonna reveal more amount of ADH as compared to lesser amount of ADH. So ADH levels are gonna be increased, right? Now there are some drugs that lead to ADH resistance in the body as well, and there are two drugs that are very important. The first one is lithium, right? So if a patient is being treated for bipolar disorder, again, if a patient is being treated for bipolar disorder, then that patient could have nephrogenic diabetes insipidus. They could give you a patient that a 35-year-old male comes to you, and so a 35-year-old male comes to you, and that male is having a difficulty in maintaining concentrated urine, right? Or that patient is having a lot of urine, right? And when you check the patient's serum osmolality and the sodium levels, both of them are increased, right? So the reverse is going to happen here, right? So the reverse is going to happen here. Here, the thing that is going to be present is that these patients are going to have increased amount of sodiums in the body, right? And there would be hypernatremia, right? Now, uh, there are some medications that cause it, and the other thing that leads to nephrogenic diabetes insipidus is hypercalcemia. Why is this important? Because we are going to have patients of hyperthyroidism, right? We are going to have a lot of patients of hyperparathyroidism, right? And when those patients are going to come to you, those patients are going to have uh, nephrogenic diabetes insipidus as well, right? And as soon as you treat the hypercalcemia, the patient is gonna get better, right? So now, what are the ADH levels in case of nephrogenic diabetes insipidus? So since I
Dr.
told you that,
Morris,
yes, I'm
Dr.
sharing my
Morris,
screen.
please. Yes,
Yes.
but I will prefer you to, like, when you speak, you can write like in a kind of short form. I retain
Okay.
information, especially in writing, than
Okay.
more of
Okay.
speaking. Yes,
Yep.
thank you.
Yep. Yep. Okay. So the patient is gonna have increase. So now look at the nephrogenic diabetes insipidus, right? So now let's look at the nephrogenic diabetes insipidus. So nephrogenic diabetes insipidus. If this was an nephron, so let me make a nephron here. So if this is the nephron, basically this is a basic nephron that is present in the body, right? So this is a proximal convoluted tubule. This is a PCT. This is the loop of Henle. This is the loop of Henle. This is the distal convoluted tubule, and this part is known as the collecting ducts, right? So now what is going to happen is that nothing is going to be working here, right? So nothing is going to be working at the distal convoluted tubule and at the collecting ducts, right? Nothing is going to work at these parts. There is going to be resistance there, and that resistance is going to cause the nephrogenic diabetes insipidus. Now, since there is resistance, the body is going to try to counteract this resistance. And how is the body going to counteract this resistance? The ADH levels in the body are going to increase, right? The ADH levels in the body are going to increase, right? And at the same time, the body is going to have hypernatremia, right? Now, for example, let's imagine that a person comes to you, right? Now, this is important, and we have to discuss this thing in detail, right? So let's imagine that a person comes to you, right? And that person is having diabetes insipidus. How can you say if it's central diabetes insipidus or if it is nephrogenic diabetes insipidus? How are you going to differentiate between both of these? And at the same time, now we have a third disease that we want to discuss as well, and that disease is known as the primary polydipsia, right? That disease is known as the primary polydipsia, and a lot of people suffer from this disease, right? So when does primary polydipsia happens? So whenever a patient is going through a period of stress, that patient, or whenever a patient is having a psychiatric illness, that patient can have primary polydipsia. So what is primary polydipsia? Primary polydipsia means that you want to drink a lot of water, right? So you are taking a lot of water, right? So whenever you are taking a lot of water, your serum osmolality is going to decrease, right? Your serum osmolality is going to decrease, right? Let's write all of these things here. So the serum osmolality is going to decrease in primary polydipsia, right? If anyone has any questions regarding the serum osmolality, anyone can ask me, right? At the same time, the urine osmolality is going to increase. Serum osmolality is going to decrease here, right? Does anyone have any questions? Why does the serum osmolality decrease in the primary polydipsia?
No.
Is
Okay.
it delusional?
Because dilution, we are taking more and more water.
Delusional sodium. Yeah.
Yes, yes. So it would be dilutional. Yes, so it would be dilutional, hyponatremia, dilutional. All the electrolytes are going to be diluted, right? So the serum osmolality is going to decrease. Whereas in case of central diabetes insipidus and nephrogenic diabetes insipidus, a lot of water is being lost from the body. So the serum osmolality is going to increase. It's going to be a concentrated hypernatremia. It's going to be concentrated hypernatremia. Now let's look at the ADS levels, right? So the ADH levels are going to be normal, right? They are going to be normal in case of primary polydipsia, right? They are almost going to be normal. Where if you look at the central diabetes insipidus, I told you the main cause of central diabetes insipidus was the fact that the body cannot absorb, cannot make any ADH. So the ADH levels are going to be very low. And the third one is the nephrogenic diabetes insipidus, in which there is resistance to ADH, right? The third one is nephrogenic diabetes insipidus, in which there is resistance. So in order to counteract that resistance, the body is going to increase the ADH levels by a lot, right? The body is going to increase the ADH levels by a lot, right? Now, now comes the fact that how can we differentiate between these three conditions, right? So if a patient comes to you and that patient has this disease, how can you differentiate what is the problem or how is this disease occurring, right? And what, because the treatment for all of the three conditions above are very different from each other, right? So in order to know about this thing, we do a test, and that test is known as the water deprivation test, right? So we do a test, and that test is known as the water deprivation test or water restriction test, right? So how do we do the water restriction test? In order to do the water restriction test, we say the patient that the patient does not have to take any water for almost 8 2 to 3 hours, right? So we say the patient that the patient does not take any water for 2 to 3 hours, right? Can anyone tell me that as soon, so what will happen if so in a normal person, if a patient is having no pathology, and I ask you that do not drink any water for like 8 hours or 10 hours, what are going to happen to the serum levels, serum osmolality and urine osmolality?
Urine osmolality
So
is high.
Urine will be
Hmm?
The
concentrated
serum
and will be
osmolarity
higher
will
osmolality.
increase
Let's
and
start from the serum osmolality. Just tell me about the serum ones.
Serum will remain
It
normal.
will increase.
it increase.
Yes, serum osmolality is gonna increase, right? The serum osmolality is gonna increase, right?
Yes.
Now, yes. So now, why is the serum osmolality gonna be increased?
because the patient keeps who urinates, because patient is normal, is not is being deprived of water and is passing urine. That means there is loss of water in the urine and patient
Okay.
is not replenished.
Yes, exactly. Yes. So now the serum osmolality is gonna decrease if a patient is having uh if a patient in a normal patient this is going to happen. So the same thing is going to happen in the primary polydipsia, right? So as soon as you start the patient on no amount of water, the thing that is going to happen is that the patient's urine osmolality and serum osmolality, so first of all urine osmolality is going to be increased. Why is the urine osmolality going to increase? Because in the body we, because the body is going to be try to is going to conserve water, and the body is trying to remove as much amount of solutes from the body as it can, right? So the urine osmolality is going to be increased. It's just like whenever you do not drink any amount of water for 5 or 8 hours or 10 hours, you will see that your urine is very concentrated and its color changes from whitish to yellowish, right? So yellow colors indicates concentrated urine because of urea and because of other electrolytes, right? Yellowish urine indicates a concentrated urine, right? So this is what is going to happen in primary polydipsia as well, right? And in order to make the urine concentrated, we are going to need ADH. And since the ADH is present in the primary polydipsia, this patient is going to have increased amount of urine osmolality. But now, if you look at the central diabetes insipidus and the nephrogenic diabetes insipidus, in both of these cases, no ADH is present, right? No ADH is present. So what is going to happen is that no change in urine osmolality is going to be observed. So this is the first step by which you differentiate between primary polydipsia and the diabetes insipidus. So first of all, we differentiate between primary polydipsia and diabetes insipidus, right? So after we have differentiated between the primary polydipsia and the central diabetes insipidus, then we move on to the next step. Now we need to differentiate between central diabetes insipidus and then nephrogenic diabetes insipidus. And it's very easy, right? So the problem that was happening in central diabetes insipidus was that we're not getting any amount of ADH in the body, right? You are not having any ADH. So how can we fix this? We can give an artificial ADH analog, which is the desmopressin, right? So we can give the patient desmopressin, and that is gonna act on the ADH receptors, and that is going to increase the urine osmolality in central diabetes insipidus, and the patient is going to be much better now, right? The patient is going to be much better, right? Whereas in the case of nephrogenic diabetes insipidus, even if we give the patient desmopressin, even if you give the patient ADH, nothing is going to happen. The urine osmolality is not going to improve, right? So this is the diagnostic algorithm or the diagnostic method by which we differentiate between these three diseases, right? This is the diagnostic method between how we differentiate between these three diseases, right? So first of all, we do a water depreciation test, right? First of all, we want to do a water restriction test, and if after water restriction test urine osmolality increases, we are going to be sure that this patient was having central diabetes, with this patient was having primary polydipsia. If no change was occurring, then we move the patient to desmopressin injection. Then we are going to give the patient desmopressin injection, and then we are going to check again. And now the patient's urine osmolality, if it increases, then the patient is having central diabetes insipidus, and if it does not increase, the patient is having nephrogenic diabetes insipidus, right? So any questions till now?
Uh,
Yeah.
Primary polydipsia once again, please.
Yes.
How to differentiate primary polydipsia? Will you repeat it once again?
Okay, sure. So remember, guys, whenever you are not drinking any amount of water, right? So whenever you are not drinking any amount of water, what is going to happen is that you are gonna have, so whenever you do not drink any amount of water, the body is gonna try to conserve water. And how does the body conserve water? So the easiest way for the body to conserve water is to secrete ADH, right? The easiest way for the body to conserve water is to secrete ADH, and this is exactly what the as the body secretes ADH, the urine osmolality is gonna be increased. Why? Because ADH is going to conserve water in the body, right? It's going to conserve water in the body. It's going to suck in all the water from the nephrons back to the body, and all the solutes are going to go in the urine, right? This is how primary polydipsia is going to work, right? So now if you do not have any amount of ADH that is functioning, or if you have ADH that is functioning but the receptors are deficient, then the problem that is going to happen is that you are not going to get the increase in urine osmolality, right? You're not going to get an increase in urine osmolality, and this is how you differentiate between primary polydipsia versus a diabetes insipidus, right? Did you get it?
Doctor, I have a question. Can you please repeat how parathyroidism causes the ADH depletion?
Can you? I didn't get your question.
How the increased calcium level causes the nephrogenic diabetes insipidus?
Okay, okay, I will go on to that as well. But it's a lengthy mechanism. Any more questions? And I'll explain it to that. Okay, so now let's go to the. Okay, so now let's go on to the calcium in nephrogenic diabetes insipidus. Right. So if you look at the ADH, what does the ADH do? Right? What does the ADH do? So if this is a hormone, if this is your cell, these are the receptors, this is the ADH, it's gonna come here, it's gonna bind here, right? And I told you as soon as it binds somewhere, it's gonna act on the aquaporins, right? And it's gonna cause the aquaporins to go here, right? So first of all, what is calcium gonna do? Calcium is gonna bind to this aquaporin, right? It's gonna form a complex with this aquaporin, and as soon as the complex forms with this aquaporin, that aquaporin is not gonna go anywhere, right? So even if the ADH binds, the aquaporin is gonna stay on this place, and no more water reabsorption is gonna occur, right? So now second thing is that high calcium levels causes the injury of distal convoluted tubules, right? At the same levels, high calcium levels are going to damage the distal convoluted tubules. And when the distal convoluted tubule becomes damaged, they are not going to respond to any hormone, right? Third thing is that the ADH acts on the CAMP pathway, right? That is the pathway on which ADH works, right? So ADH is going to work on the CAMP pathway. It's going to increase the level of cyclic adenosine monophosphate in the body, right? And how does it increase the level of cyclic adenosine phosphate? It acts on the adenylate cyclase, right? Adenylate cyclase is the enzyme which is going to increase cyclic AMP, and that is going to cause the aquaporin binding. Now, what is going to happen is that calcium is going to block this enzyme. Calcium is going to inhibit this enzyme. It's going to restrict this enzyme. And when you get restrict this enzyme, the patient is going to have polyuria, dilutional hyponatremia, and all of those things, right? So this is how calcium is going to cause the nephrogenic diabetes insipidus. Okay. Now let's move forward. So this was the first two topics. Now we are moving on to the third topic, which is the acromegaly, right? So what is acromegaly? So acromegaly is very simple. Acromegaly means that in adults you are having an increased amount of growth hormones, right? After a patient has become an adult. So adult means that the patient has gone through puberty. So if a patient has gone through puberty and now that patient is having increased amount of GH in the body, right? That thing is known as the acromegaly, right? Why is this different from gigantism, right? So gigantism is a condition in which you are having increased amount of ADH, increased amount of GH hormone when the patient is a baby, right? When the patient is small. Why is this different? This is different because if you are having gigantism, if the patient is not yet achieved puberty, then the patient's bone can grow when the patient's epiphyses are not closed, right? And okay, I'll repeat the CA and EDH as well, right? So the patient's epiphyses are not closed. The patient can still have growth of the long bones. So the features of gigantism and acromegaly are very different, right? Now, what will happen in the case of gigantism is that in acromegaly, sorry, acromegaly is that you are going to get a patient. So the USMLEs are going to give you a patient and they are going to say that a person comes to you in his 30s or 40s. And remember, gigantism usually happens due to some kind of pituitary adenoma of a pituitary tumor, right? It's going to happen in 20 or 30s or 40, and the patient is going to have a pituitary tumor. The most important thing that is present here is that there what will be the features that will be present in gigantism. The patient's tongue is going to increase in size. The patient's head is going to get frontal bossing, right? So the forehead is going to get very large. It's going to protrude forward, right? The patient's facial features are going to get very coarse or very aged, right? The patient's voice is going to be very deepened, right? And the most important thing that is present, the patient's fingers are gonna get very thick. The patient's foot are gonna get very thick, and I don't think that thing is mentioned here in the in the first aid, but that is the most important thing. Why is that the most important thing, right? This is the most important thing because this is the feature that is gonna tell the patient that he is having acromegaly, right? So a lot of patients come to you for different problems, right? A patient is not going to come to you and going to say that my tongue is increased in size. This is the thing that you are going to notice. But the patient is going to come to you, and the first thing that a patient is going to say, so if the patient is a woman, the patient is going to say, my rings do not fit on my fingers anymore, right? Or I cannot wear my gloves anymore, right? Or my shoes do not fit me anymore, right? These are all the complaints that the patient is going to have. So the patient is going to come and the patient is going to say, that my hands are so wide or my feet are so wide now that I cannot now put on all those things in my hands, right? So, or my foot, right? So this is the first thing, right? That the patient is going to have, and then you're going to see that the patient's voice is deepened, right? The patient's tongue is very large, right? The patient, it is in a very bad condition. The patient again is having a doughy texture, and the patient is having hyperhidrosis, right? So these are all the signs and symptoms with which the patient with acromegaly is going to come to you, right? The patient's hands are going to increase in size, the patient's tongue is going to increase, right? The patient is only going to have frontal bossing, right? And if you compare it to gigantism, which happens in children, right? So gigantism is going to happen in juniors, right? So G for gigantism and G for juniors, right? So we don't write juniors with J, we write juniors with G. So G for gigantism, G for juniors, A for acromegaly, A for adults, right? A for acromegaly and A for adults. So A for acromegaly, A for adults, and G for gigantism, and G for juniors, right? Now, the most important thing that the USMLEs and UWorld are going to mention is that whenever a patient is having acromegaly, the patient is going to have a growth of his heart as well, or her heart as well, right? The heart is going to grow. And I told you earlier, whenever the heart is going to grow, left, you are going to have hypertrophy of the left heart, right? And if a patient is having hypertrophy of the left heart, the patient is going to have heart failure with preserved ejection fraction, right? Hypertrophy of left heart, that is going to lead to heart failure with preserved ejection fraction. And this is the most common cause of death in acromegaly, right? They are going to give you this question and they are going to ask you that a patient comes to you and the patient is having frontal bossing, the patient is having deep tongue, the patient is having macroglossia, the patient is having the increased amount of hands and feet, right? The size are going to be increased, and then they're going to ask you how is the patient most likely going to die. The patient is most likely going to die from heart failure with preserved ejection fraction, right? At the same time, there is going to be left ventricular hypertrophy, and the patient is going to have diabetes as well, right? The patient is going to have diabetes as well. And why is the patient going to have diabetes? I explained this thing to you earlier yesterday, right? So the diabetes is going to be present because remember, whenever a patient is having increased amount of GH, the patient is going to have insulin resistance. So the patient is going to have diabetes as well. How can you diagnose it? So in order to diagnose it, you have to do two things. So first of all, you have to do two things. So first of all, you do check the serum IGF-1 levels, right? So you check the serum IGF-1 levels because I told you that GH increases the amount of serum IGF-1 levels, right? So you're gonna check the serum IGF-1 levels, right? And those are gonna be increased. Why can't you check the growth hormone levels? Because the growth hormone levels fluctuate throughout the body, right? So the GH levels are going to fluctuate throughout the body, throughout the day. And when, so, okay, so there is going to be concentric hypertrophy, right? There is left ventricular hypertrophy, right? Okay, wait. Okay, so now, uh, first of all, now you check the serum IGF levels. The serum growth hormone levels are gonna change throughout the day, so that is not gonna be important, right? So you are gonna check the serum IGF-1 level. Second thing is that if you pay, second thing is that I told you that hyperglycemia causes the inhibition of growth hormone. Whenever you are having high amounts of glucose, the body is not gonna secrete any more growth hormone, right? So what do we? So this is known as the glucose, so that is known as the oral glucose loading test, right? That is known as the oral glucose tolerance test or the oral glucose loading test. So you are gonna, so if you confirm that the patient is having high IGF levels, the next thing that you are gonna do is you are gonna give the patients, now you're gonna give the patients glucose. And when you give the patients glucose, you are gonna see that the patients so now you'll give the patients glucose, and after giving the glucose, you are gonna see the patient's growth hormone. Is it decreasing or not? Right? If it does not decrease after giving glucose, then it's confirmed that the patient is having acromegaly, right? And the treatment is very simple. I have already told you that the treatment is pituitary adenoma resection, right? So remember, in some diseases, you go with the medical management first, and then you go to the towards the surgery. But in some diseases, we do the surgery first, and then we need to the medical management. It depends on different diseases. In the case of growth hormone excess, we are gonna do the the surgical management first. We are gonna remove the pituitary adenoma. But if the even after the surgery, the patient is not cured, then we are gonna give the patients octreotide, right? Then we are gonna give the patient octreotide. Now, if that does
Doctor?
not solve the problem, yes.
Well, so you said first we do the MRI and the surgery. After that, we're gonna go for the treatment, or vice versa.
Okay, so first of all, we do the surgery, right? And if surgery solves the problem, then it's good. We do not do any more thing, right? But sometimes even surgery leaves some kind of pituitary adenoma behind, right? Some amount of pituitary adenoma is left behind, and that pituitary adenoma is gonna cause a lot of problems, and you cannot remove that pituitary adenoma by doing another surgery. So in that case, you give the patient octreotide, right? So you give the patient octreotide, and what does octreotide do? Octreotide is a somatostatin analog, as we discussed earlier, right? So octreotide is a somatostatin analog, and it's gonna decrease the secretion. It's gonna reduce the secretion of glucose, right? That is gonna reduce the secretion of glucose, and the glucose secretion is gonna be low now. Sorry, the GH secretion is gonna be low now, right? Or you can give two other things. You can give the patients dopamine agonist. So remember, dopamine also inhibits the secretion of GH, right? So you can give the patient dopamine agonist, or you can give the patient GH receptor, कोई भी GH receptor agonist, right? So you can give the patient GH receptor antagonist, right? So what are the GH receptor antagonists? The GH receptor antagonists are the pegoizumab, right? Okay, so there was a question: how do you differentiate acromegaly versus Marfan syndrome? Right. So that is the first. So I told you that the patient of acromegaly won't be tall. The patient would be normal in height and in everything because the body has already completely grown. Anything of the body is not gonna change now, right? Anything of the body is not gonna change now. The body is gonna just gonna have thickened amount of fingers. The foot are gonna be thickened. The tongue is gonna be thickened, right? So that is not gonna change. In case of gigantism, the body is going to be enlarged, right? So the patient is going to be very large in case of gigantism, but it's very different from marfanoid. Why? Because in case of marfanoid, in case of gigantism, the whole body is going to be very tall, right? So if any one of you have watched Game of Thrones, right? There was a character that was named the Mountain, right? So if you look at the mountain was very large. He was very tall, right? Everything of that patient was very tall, right? Whereas if you look at a patient of Marfanoid's habitus, the whole of the patient won't be tall, right? The patient's torso or the patient's chest and abdomen are gonna be very small, and the rest of the patient is gonna be very large. So the the legs and the arms are gonna be very, very, very large in case of Marfanoid habitus, right? And you are going to feel that thing in case of marfanoid habitus, right? So the patient is not going to be a giant. The patient is going to look very weird, right? The patient is going to go very weird in the case of marfanoid habitus, right? Whereas in case of gigantism, the whole patient is going to be very tall, right? So let me show you. So look at this picture, right? You can clearly see here how long the arms are, right? So if you look normally at a patient, the arms do not go as far as further as in this patient, right? And the legs are so large as well, right? Now let's look at the picture of a gigantism, right? So let's look at gigantism picture. So this is a picture of a patient who was having gigantism, right? So now look at the torso. Now look at the chest and the abdomen and the torso. It's so large. It's larger as compared to the hands and other things, right? So this is how gigantism is going to present, and they are going to mention to you in this question, right? So that thing they are going to mention in the question. The patient, if they mention that the patient is having increased amount of arm to leg, so if they're going to mention that the arm to torso ratio is increased, right? Or the arm to chest ratio is going to be increased, then the patient is going to have marfanoid habitus. But that thing is not going to happen in gigantism, right? Okay. Now let's move forward. Mm, okay. Okay. So, any questions? Any more questions? If not, let's move forward.
Yes. Can I ask a question?
Yes.
Okay. So the difference, is there a way to just maybe summarize by saying that, maybe let me ask the question this way. Is gigantism has a slim habitus like Marfan does? Because Marfan in most of the question in step one talks about a slimmer habitus. Is gigantism can be the same thing, or they're usually more opulent on the statue wise?
Okay, so the patients of gigantism are going to be very much pumped, right? They're going to be very thick. They are going to have big muscles. They are going to have more amount of growth, right? And they are going to be very pumped up and very stocked up, right? And there is a pathophysiological reason for it as well. Why? Because if you look at the functions of GH, we saw that how GH increases the protein synthesis, right? So GH is going to increase the protein synthesis, and they are going to have an increased amount of muscles, right? Whereas if you look at Marfan syndrome, you're going to see that there are problems in the fibrillin protein. There are problems in the protein formation, right? So, and the scaffold for the protein is not good. So those patients are going to be thin. Whereas, yes, you're right. The patients of gigantism are going to be very much thicker. They are going to have increased amount of muscle, and their overall structure is going to be very wider. Right? They are going to be wide as well, right? So remember another thing: Marfanoid patients are not wide, right? They are tall, but they are not wide, right? But the patients of gigantism are wide as well. Why? Because the clavicles are the one thing that are gonna give you width to the body, right? Clavicles and ribs give you all of the width to your body, right?
Okay.
And the pelvis as well, right? And the pelvis and the hip bones and the clavicles and the ribs, they are gonna get much more enlarged in gigantism. Whereas in the case of Marfan syndrome, only the humerus, only the femur, only the tibia, only the fibula, and only the radius and the ulna, they are going to get enlarged, right? So the patient is going to just going to have large limbs, right? Whenever we are going to do the musculoskeletal system, we are going to go into the detail of endochondral ossification, what is the cartilaginous ossification, right? And then we are going to go into the details as well, that how GH affects both, whereas in Marfan only one is affected, right?
Okay. Thank you.
Oh, you're welcome. Right. So now, so I wanted to start thyroid's problem as well today, but I think we'll have less time if we start thyroid. So instead of thyroid, we are going to do another topic today, right? And this is very important. And since I was listening at the last question, so that makes a complete sense, right? So this is the pheo. So we have a pheochromocytoma, right? This is very important. This is very easy. So keep this thing in your mind. This is very high yield, right? So what is pheochromocytoma? So if this is your kidney, if this is your kidney, right? So if this is the one kidney, this is the second kidney. On top of the kidney, we have an adrenal gland, right? And okay, so now what we are gonna see is that in case of this is known as the adrenal gland, right? So the adrenal glands are gonna have two parts. One is the outermost adrenal cortex, and the inner part is known as the adrenal medulla, right? And the adrenal medulla secretes the epinephrine and the norepinephrine, right? The adrenal medulla secretes the epinephrine and norepinephrine, and from the adrenal medulla we are gonna get the chromaffin cells, right? So the chromaffin cells lead to the formation of adrenal medulla, or and these chromophil cells come from the neural crest cells. I am telling you these things because these things form the pathophysiology of the pheochromocytoma, right? These things are going to form the pathophysiology of the pheochromocytoma, right? So this is how pheochromocytoma occurs. Now sometimes what will happen is that this adrenal medulla is going to have a tumor, right? And this is the most common tumor of adrenal medulla, and this is going to come from the neural crest cells, which are going to drive from the chromaffin cells, right? Now, whenever you are going to have a tumor of this, all of a sudden you are going to have increased amount of epinephrine, right? you're going to have an increased amount of epinephrine, and that increased amount of epinephrine is going to cause the blood pressure to shoot all of a sudden. You are going to have throbbing headache all of a sudden. You are going to have heart palpitations and tachycardia all of a sudden. Why? Because epinephrine is going to act on the beta 1 receptors and the alpha 1 receptors, right? And beta 1 receptors are going to cause increased amount of stroke volume, and it's going to increase the tachycardia as well. So you're going to have palpitations, right? It's going to constrict the blood vessels in the brain, and when the blood vessels are going to be constricted, you are going to have headache, right? It's going to increase the abdominal pain. You are going to have abdominal pain. You are going to have anxiety. You're going to have pallor. You're going to have palpitations and tachycardia. But remember, the patient is going to have all of these things in a, what do you saw at episodic pattern. So it's going to occur for some times, and then it's going to be increased. It's going to be improved, right? So this is how a patient of pheochromocytoma presents to you. Now, there are some mutations that are associated with the pheochromocytoma, right? What are those mutations? The so the first mutation is the RET mutation, right? So what is the RET mutation? So we have RET mutations in two things, and that is known as the MEN2A and the MEN2B. MEN2A and MEN2B, right? So these, so MEN2A and MEN2B are two conditions that we are gonna study today, right? Besides that, we have the VHL mutations and we have the NF1 mutations, right? VHL mutations are going to be studied in the renal portion, right? So the next system is renal, and after that, NF1 is going to be studied in the neuro portion, right? And then we are going to go into the detail of VHL, von Hippel-Lindau, and the neurofibromatosis 1 mutations. But these mutations are important, right? So what is going to happen is that these tumors are going to secrete epinephrine, norepinephrine, which is going to cause hypertension, right? And these are going to occur in spells, right? So how do we diagnose this condition? In order to diagnose this condition, we are going to check the catecholamine levels in the urine and plasma. And we are going to check the catecholamines level in the urine and plasma. And remember, catecholamines such as epinephrine, norepinephrine, they're also known as the metanephrines, right? So these are going to increase the glucose as well. So one incidental finding that you're going to find in pheochromocytoma is that you are going to have increased amount of glucose in the blood, right? You are going to have increased amount of glucose that are going to be present in the blood. So for pheochromocytoma, I use a mnemonic. That mnemonic is the 5 P's, right? 5 P's, right? So first of all, P stands for pheochromocytoma, right? P stands for pressure. So the blood pressure is gonna be increased. It stands for pain. So there is gonna be head pain. P stands for perspiration. So there is gonna be increased amount of sweating, right? P stands for palpitations. So and P stands for pallor, right? All of these things are going to occur here. Now, how do you diagnose? So first of all, the most important thing is that you are going to check plasma free metanephrines or urinary metanephrines. Plasma free metanephrines and the urinary metanephrines. This is the first test that you are going to do in these patients, right? You're not going to do an MRI. You're not going to order a CT scan. The first step that you are going to do is plasma metanephrines or the urinary metanephrines. If they are positive, then yes, do you do a CT scan, right? And then you confirm what is present in the patient, right? After that, what is the treatment? What is the treatment? Treatment is very important. So for the treatment, you have to do a surgery, right? Surgery is the only definitive treatment for this condition. Only surgery is going to treat pheochromocytoma. If you are doing a surgery, that is going to lead to the removal of pheochromocytoma. But remember, pheochromocytoma is a very dangerous disease, and its surgical outcomes have very bad mortality and very bad morbidities. And why is that? Why is that the patients of pheochromocytoma have very bad outcomes after surgery? Because if you do not control the pheochromocytoma well before the surgery, what is going to happen is that all of the pheochromocytoma is going to get bursted in during the surgery, and that is going to lead to a very bad outcome, right? You're going to have hypertensive crisis during the surgery. All of the epinephrine is going to be released into the blood, and that is going to lead to disastrous outcomes, right? So, in order to solve that condition, what do we do? Before the surgery, we control the pheochromocytoma. And in order to control the pheochromocytoma, first of all, we give the patients alpha antagonists, right? So, epinephrine acts mainly on the alpha receptors, norepi, and they are going to act on the alpha receptors. So, we give alpha antagonists. And we have to give irreversible alpha antagonists. And what is that? That is phenoxybenzamine, right? So, we are going to give the patients phenoxybenzamine, and after alpha 1 antagonism is done, we are going to give the patients beta blockers. So why is that we give the patients alpha blockers first and we do not give the patients beta blockers? Anyone?
To prevent hypertensive crisis.
I think one is irreversible, the other one is reversible. I think phenoxypenicillin is irreversible.
Why does hypertensive
No, no,
crisis
no.
comes in this
Actually,
way?
it's the why alpha because there is increased SVR due to the alpha receptors. First, we give the alpha blockers, and it will relieve the means the heart from compression means.
Okay, so
And
remember this thing. We
So
have
why?
two receptors. So in the blood vessels, we have two receptors. One is the beta 2 receptors, one are the alpha 1 receptors, right? And beta 2 receptors lead to vasodilation and they reduce the amount of blood pressure, right? Whereas the alpha 1 receptors increase the blood pressure, right? Beta 2 receptors reduce the blood pressure, whereas alpha 1 receptors increase the blood pressure, right? Now, for example, now these two receptors are working side by side. So, if you give a patient epinephrine, the patient's blood pressure is going to be increased due to alpha 1 receptors, and somewhat they are going to be decreased due to beta 2 receptors as well. But remember, the effect of alpha 1 receptors are much more greater than the beta 2 receptor, right? So, the patient is going to have, so the patient is going to have much more increased effect of the alpha 1 receptors. So wow, what if I mistakenly give the patients beta blockers? What is going to happen is that these the beta receptors, so if you block the beta receptors, the vasodilatory effect of epinephrine is going to go away, right? And due to the vasodilatory effect of the epinephrine getting away, now you're going to have only the vasoconstrictive effect, right? That is why you're going to get a hypertensive crisis. So that is why, first of all, you are going to give the alpha 1 blockage, and after the alpha 1 blockage, you are going to lead to the beta blockers, right? So always give a alpha blocker before a beta blocker, right? And this is very important, right? Keep this thing in mind. This pathophysiology is very important as well, and it can come into your exam, right? That why do we give beta blockers? And believe me, a lot of people do not about why do we give alpha blockers. No, we have not covered the adrenal steroidogenesis. Right? So the information comes to you, right? So information comes to you. Are you going to give patients alpha blockers first or beta blockers first, right? So remember, epinephrine, when you do the pharmacology, you're going to see that epinephrine has some interesting effects. So epinephrine are going to have some interesting effects.
Dr. Moaz, your voice is breaking. Your voice is breaking. We can't hear you.
Hello guys, can you hear me?
Yes, we can hear you now, but before now, we
yes,
weren't
you can hear.
hearing you.
Hello, can you hear me guys?
Yes.
We-
No.
So we have the alpha 1 receptors and we have the beta 2 receptors on the blood vessels, right? What do the beta 2 receptors do, right? And why do we have two types of receptors that are present in the blood vessels, right? Why do we Sorry guys, I'm having a little connection problems. I hope it's okay now.
Yes.
Okay. So I was telling you guys that we have two types of receptors that are present on the blood vessels. We have the alpha 1 receptors and the beta 2 receptors that are present on the blood vessels as well, right? So each of these receptors works. Alpha 1 receptors block the blood vessels, whereas the beta 2 receptors dilate the blood vessels and they reduce the blood pressure, right? Whenever we are having a patient with pheochromocytoma, you are gonna see that these patients are gonna have epinephrine that are gonna be acting on the alpha 1 receptors and the beta 2 receptors as well, right? And the beta 2 receptors are gonna be much more stronger than the alpha receptors, right? So the beta 2 receptors are gonna be much more stronger than the alpha 1 receptor. Alpha receptors are gonna be much stronger than the beta. As a result, you are gonna get a patient that is gonna have hypertension, right? Now, if you give the patients beta blockers, the vasodilatory effects of the beta 2 receptors are going to go away completely. Now, this patient is going to have much more higher blood pressure, right? Even than before, right? So, that is why we do not give beta blockers first, we give the alpha blockers first to prevent the hypertensive crisis, right? Any other questions? Yes, Gabriel? Yes?
Before the end of the lecture, can you go back over the high calcium and ADH and then glucose and the growth hormone?
Okay, sure. So the high calcium, okay. So regarding the high calcium and glucose, right? So remember the fact that whenever a patient is having high calcium, right? So remember, first look at the ADH, right? So the ADH is gonna work on the nephrons, right? The ADH is gonna work on the nephrons, right? The ADH is gonna activate the adenylate cyclase, right? ADH works on the adenylate cyclase. It activates the adenylate cyclase that increases the CAMP level. So adenylate cyclase is going to increase the level of cyclic adenosine monophosphate, right? So the levels of cyclic adenosine monophosphate increases in the body. When the level of cyclic adenosine monophosphate increases in the body, you are going to get increased amount of water reabsorption through the aquaporin channels. But all of a sudden, whenever you are having high level of calciums, the calcium is going to block the adenylate cyclase. And when the adenylate cyclase is going to be blocked, the ADH is not going to work, right? The ADH won't be able to insert its aquaporin channel uh, into the into the receptors or into the wall, right? That is why whenever UWorld and UWorld and USMLEs and NBMs are gonna give you a question regarding PTH or parathyroid hormone, right? Or even ADH, they are going to mention adenylate cyclase, right? They are going to mention CAMP, right? Because CAMP is very important. If you are going to have CAMP, then the ADH is going to work, else it's not going to work. So every time they are going to mention the urinary CAMP levels, they are very important, right? The second thing that was important and that I was telling you guys was the growth hormone. How do you diagnose the acromegaly, right? So the definitive test for the diagnosis of acromegaly is glucose tolerance test or glucose loading test, right? Why? Because remember, so what is glucose loading test? First of all, let me tell you what is glucose loading test. So whenever a patient with suspected acromegaly comes to you, we are gonna check the patient's growth hormone levels, right? Whenever a patient with suspected acromegaly comes to you, you are gonna check the patient's growth hormone levels, right? And since the growth hormone levels are changing throughout the day, that is not an important thing. So what do we do is that we check the patient's IGF levels, right? So we are going to check the patient's insulin like growth factor levels, right? And they are going to be increased in case of acromegaly, right? IGF levels are going to be increased. But how do we confirm the diagnosis? Now we give the patient's glucose, right? Inject the patient with IV glucose, right? And normally glucose inhibits the secretion of growth hormone. Again, the higher the glucose that is present in the body, the lower is going to be the amount of growth hormone in the body, right? So if we give the patient's glucose and the growth hormone level is suppressed, then the patient is not having acromegaly. But if there is a tumor, and if a tumor is present, then there would be a lots of growth hormones, and that growth hormone is not going to be stopped by the glucose, and that is going to confirm that this patient is having acromegaly, right? Now this brings me to another clinical physiology or clinical pearl, that is whenever a person who is doing bodybuilding, he is going to inject growth hormone, right? That patient is going to inject growth hormone. Why? Because growth hormone increases the protein synthesis. It is going to give the patient better amount of muscles, right? The patient's muscles are going to be increased. But whenever a patient injects himself with glucose with growth hormone, at the same time the bodybuilder injects himself with insulin as well, right? Patients injects himself with insulin as well. Why? Because insulin is going to lower the glucose levels, and when the glucose levels are going to be lowered, you are going to get increased amount of growth hormone in the body. So this is a synergistic effect of growth hormone and insulin, right? Growth hormone needs hypoglycemia, right? Growth hormone needs hypoglycemia. Growth hormone loves hypoglycemia. So whenever there is hypoglycemia, growth hormone is going to thrive, and whenever there is hyperglycemia, growth hormone levels are going to be low, right? So that is how growth hormone and glucose go hand in hand, right? Any other question? Guys, any other question? You're welcome. Is there anyone have any other questions? We can do some more questions if anyone wants regarding any other topic that we have discussed today, or in the physiology portion, or any other topic, right? Yes, yesterday's lecture was recorded, and I think Dr. Hamza or Dr. Ahmed will upload it today, right? Into the today's lecture as well. That will be uploaded as well, right? So SIADH hormones, right? So let me recap the SIADH for you as well, and the diabetes insipidus for you as well, right? Yes, Gabriel. Okay, okay. I will go over the euthyroid 6 syndrome as well, right? So what is euthyroid 6 syndrome? So remember, yes.
The question is yesterday's topic. Can you go over why oral glucose is better absorbed than IV glucose and the role of the incretins?
Okay. So no, so both of the glucose are absorbed well. The question thing that we were discussing yesterday was whenever a patient is having, so for example, you have two patients, right? You give one patient 100 gram of glucose via the oral route, and you give the other patient 100 gram of glucose via the IV route, right? The patient who was given oral amount of glucose, that patient is going to have increased amount of insulin, right? This was the thing, right? So the patient to whom you give oral glucose, that patient is going to have increased amount of insulin. And why is that? Because in our GI tract, we have some receptors, right? In our GI tract, we have some receptors for the glucose, right? And whenever those receptors are being activated by the glucose in the GI tract, the GI tract is going to release some hormones, and those hormones are known as the incretins, right? Those hormones are known as the incretins, right? So the incretins, what do the incretins do? So the incretins are going to increase the amount.
Um,
Basically, they are
can't hear.
okay. So let me explain it again. So what I was telling is that, so for example, you have two persons, and to one person you give 100 gram of glucose in the oral form, and to the other person you give 100 gram of glucose in the IV form. To that person to whom you have given the 100 gram of glucose in the oral form, that patient is going to have increased amount of insulin production as compared to that person who is having 100 gram of glucose in the IV form. And why is that? This is due to the fact that in the oral form, whenever you give the patient glucose in the oral form, that glucose is going to act on the receptors in the GI tract, right? And glucose is going to act on the receptors on the GI tract, and the GI tract is going to secrete some hormones that are known as the incretins. And what are the incretins? Incretins are glucagon-like properties. They are the GLP-1, right? And when that incretin is going to increase the amount of insulin that is present, right? This is how incretins work. Now let's move to euthyroid 6 syndrome. If you have understood this, is everything clear regarding this?
Yes, go with euthyroid.
Okay, so let's move to euthyroid 6 syndrome. So euthyroid 6 syndrome was the old name for euthyroid 6. So now we use the name non-thyroidal illness syndrome, NTIS, right? So that is the name of non-thyroidal illness syndrome, right? So what is this thing? So remember I told you that we have a hormone which is known, we have an enzyme which is known as the 5 prime deiodinase, right? We have a hormone which is known as a 5 prime deiodinase. And what does the 5 prime deiodinase does? So the 5 prime deiodinase converts the T4 to the T3, right? So it's gonna. So now tell me, what is the active form of thyroid hormone? T3 or T4?
T3.
T3.
Yes, so T3 is activated. So whenever a patient is in the ICU, or if a patient is having very increased amount of severe illness, right, or the patient is in very severe stress or very severe physical stress, what is going to happen is that the thyroid functions are going to be normal, but the body is going to secrete interleukin 6, right, and that interleukin 6 is going to that interleukin 6 is going to cause reduced formation of T4 to T3, right? So you're gonna see a patient whose T4 levels are gonna be normal, but whose T3 levels are gonna be reduced, right? The T3 levels are gonna be reduced, and as a result, T4 levels are gonna be reduced as well. Why? Because if someone asked me yesterday, right? Someone asked me yesterday, what is reverse T3, right? So as a result, what is the interleukin 6 gonna do? The interleukin 6 is gonna convert the T4 to reverse T3, right? Interleukin 6 is going to convert the reverse. No, I'm not sharing the screen, right? So it's going to convert the T4 to reverse T3, right? So the reverse T3 is going to increase, the T4 is going to decrease, the T3 is going to be decreased as well, right? All of these things are the T4, T3 is going to be decreased, and the reverse T3 is going to be increased, right? Now, this is the way that euthyroid 6 sinus syndrome or non-thyroidal illness syndrome comes to you. They're going to give you a patient whose TSH is going to be normal, right? His T3 and T4, both of those things are going to be low, right? His both T3 and T4 are going to be low. And then they're going to ask you, what is the most likely diagnosis? So the most likely diagnosis is going to be that euthyroid 6 syndrome. And what is the treatment for this condition? There is no treatment. You do not do any treatment. You just treat the root cause and the patient. But there is one very bad news. Euthyroid 6 syndrome is an indicator of mortality and morbidity. If a patient is having euthyroid 6 syndrome, there is a very high chance that this patient is going to die, because euthyroid 6 syndrome indicates that the patient is undergoing through a very serious illness, right? The patient is very sick. This is what euthyroid 6 syndrome tells us, right? So if a patient comes to you and that patient is having euthyroid 6 syndrome, just imagine that this patient is having very much life that is left of him, right? And when do you suspect euthyroid 6 syndrome? Any patient who is having less T3 or is having less T4 and the TSS is normal, right? And there are no symptoms of hypothyroidism. Remember this thing. A patient of euthyroid 6 syndrome is not having any signs and symptoms of hypothyroidism. Yes, exactly, Dr. Y. It's a poor prognostic indicator, right? It's a very poor prognostic indicator if a patient is having euthyroid 6 syndrome, right? It just means that the body is the body is at such a critical state that the body thinks the that we do not need any more T3 right now, right? Any more T3 is going to be not going to be beneficial for the body, right? So the body thinks we do not need any more T3 right now. Even we do not need any more thyroid hormones right now. We are going to work on other things. The body is going to conserve the basal metabolic rate. The body is going to conserve the energy needs, and in order to conserve the energy needs, the body is going to decrease the thyroid hormones, right? So this is how euthyroid 6 syndrome occurs, right? So any other questions regarding any of the topic that we have studied till now?
Dr. Moss, for euthyroid 6 syndrome, Dr. Mahin said that cortisol decreases iodination, was it?
Yes, so cortisol decreases iodination as well, right? But mainly in case of euthyroid 6 syndrome, it's the interleukin levels, right? So the IL interleukin levels. So the cortisol is going to decrease the iodination as not going to decrease the iodination. It's going to affect the 5 prime deiodinase. It's going to decrease the deiodination, right? not the
Yes, sorry.
iodination, the
Yes, sorry.
deiodination.
Dehydrated. And
Yes, but
then RT3 will be high.
yes, the RT3 will be high. The RT3 is an inactive metabolite of T4, right? That is gonna be high, but it's not the cortisol, it's the interleukin 6, right? These are the cytokines that are gonna affect the TSH and thyroid hormones, right? Okay, because
Right.
if cortisol blocks the, okay, so remember this thing, right? Remember this difference between euthyroid 6 syndrome. What is the cortisol thing, right? If you are giving patient increased amount of cortisol, the 5 prime deiodinase is going to be blocked, but the patient T4 is going to be increased, right? The patient's T4 is going to be increased, whereas in euthyroid 6 syndrome the T4 is going to be decreased as well in a lot of cases, right? And the T3 is going to be increased, the reverse T3 is going to be increased, right? And that is going to be increased with the help. Okay, so right now, what was it? Okay, so the growth hormone concept, let me repeat it once again, right?
Dr.
Remember,
Mars, you didn't finish that. The dehydration bit. So once IL-6 is high, then what happens?
so when the IL-6 is happen, right, the 5 prime deiodinase stops working, right? The 5 prime deiodinase is going to stop working, right? It's going to stop working, and instead we are going to have another thing, that is the 5 prime monoiodinase, right? So that is known as the 5 prime monoiodinase, right? That is going to increase work, right? And 5 prime monoiodinase converts T4 to reverse T3, right? It's going to convert T4 to
Thank you.
reverse T3, and it's going to convert T3 to T, right? It's going to convert the T3 to T2, and it's going to convert the T4 to reverse T3, right? This is very advanced level physiology and endocrinology, right? They are not going to ask you this, but I'm just telling you this. So 5 prime monoiodinase is going to be activated. 5 prime deiodinase is not, will not be working anymore. Right, 5 prime deiodinase is going to be blocked. It's going to be blocked due to the interleukin 6, and 5 prime monoiodinase is going to be activated, right? And when 5 prime monoiodinase is going to be activated, it is going to increase the reverse T3, right? Reverse T3 level is going to be high, right? And nowadays the best test that you can do for in euthyroid 6 syndrome is measuring the reverse T3 levels, right? It's checking the reverse T3 levels, and they're gonna be increased, right? Now, again, growth hormone, right? So I have told you this, that growth hormone is a hormone that is secreted whenever a body is having low amounts of glucose, right? It was an evolutionary mechanism, and that was whenever the body is having hypoglycemia, right? Whenever a body is having hypoglycemia, the growth hormone levels are gonna be increased. Whenever a patient is suffering from hypoglycemia, the growth hormone levels are gonna be increased. And whenever a patient is having hyperglycemia, the growth hormone levels are going to be decreased. Now, growth hormone is very good for bodybuilding, right? It's very good for building muscles. It's very good for building biceps. It's very good for building thighs, right? So bodybuilders want the maximum amount of growth hormones, right? Because if you get the growth hormones from outside, it's going to be expensive. If you are going to make in the body, it's going to be cheap, right? So what do the bodybuilders do? The bodybuilders insert a lot of insulin. Why? Because insulin is going to induce hypoglycemia in the body, right? Insulin is going to induce hypoglycemia in the body, and when you are going to get hypoglycemia, the thing that is going to happen is that it is going to increase the growth hormone levels, and the growth hormone levels are going to be increased, right? And when the growth hormone levels are going to be increased, you are going to get increased amount of muscle growth. So whenever a patient comes to you, or whenever a bodybuilder is coming to you, that patient is going to take growth hormone, and that patient is going to take insulin as well, right? So please try to interconnect these things as much as possible, right? What's the insulin gonna cause? What's the growth hormone gonna cause? How will incretins work? How do incretins interact with the growth? How do the incretins interact with the Ozempic, right? How do the incretins interact with the GLP-1 analogs? Why? Because these things are very important in the step one. These are the pathophysiologies, and they are gonna go into the step two and step three as well, right? So I was having my rotations at the University of Cincinnati, right? And I was doing my observerships there, and I met with an ICU doc there, right? So he was a doc in the medical intensive care unit, and I remember that day that he asked me this question that, do you have any idea how does the euthyroid 6 syndrome works, right? And he asked me about the 5 prime monoiodinase, right? And he was very happy when I answered that question, because he told me that most of the US medical school graduates do not know these pathophysiologies, right? They do not know the pathophysiology, right? It's very easy to remember all of the clinical features. It's very easy to remember the diagnostics. It's very easy to remember the treatments, right? USMLEs, it's not about this. You can go to ChatGPT, you can ask the treatment for any condition. You can go to ChatGPT. Remember, there was a press release from USMLE Step 1. If you go into the USMLE Step 1 bulletin and news, there was a press release from the bulletin, and that press release mentioned that how ChatGPT has came and how ChatGPT is changing the medicine, right? And USMLE told that how we would be changing our questions regarding ChatGPT. So we would focus on those questions that checks the patient's instinct and the patient's in and and the test taker's intellects, right? So as you move forward, try to build these things, because if you give 6 symptoms to ChatGPT, the ChatGPT is going to tell you what the diagnosis is. But try to focus on the concepts, try to focus on the understandings, right? Why? Why is the reverse T3 increasing, right? Why is the T4 levels and the T3 levels are decreasing? Just don't cram that in euthyroid 6 syndrome T3 and T4 levels are going to decrease, right? Remember, why are they decreasing? What enzymes are working on this pathway? Why are the enzymes working like that? Just don't cram that hyperglycemia is going to cause decreased amount of glucose. Remember its clinical significance. Why does hyperglycemia reduces growth hormone levels? Why do hypoglycemia increases growth hormone levels? Because whenever there is hypoglycemia, you are going to need increased amount of energy in the body. And in order to get this energy, you are going to need growth hormone. That is why this thing is going to work in this way, right? Why is euthyroid syndrome happening, right? And I'm here with you. I'm going to guide you on all of these things, right? So understand the concepts, right? Whenever you are when you are done with step 1, you are going to do step 2, right? And you are going to see in step 2 there are a lot of algorithms, right? And a lot of patients and a lot of people I understand, I met with, they just cram those algorithms, right? So if a patient come with this, just do echo. If a patient comes with that, just do this. It does not work like that. There is a reason for everything, right? There is a reason for everything, and you have to go with the reason, right? You go with the reason, and that is going to help you as well, right? So for example, let me tell you another interesting thing, right? So we have studied that so we have studied that the heart failure increases the BNP levels, right? So when I was doing rotation, I saw a doc and I saw that even the BNP levels were increasing. The patient did not have any clinical symptoms, right? And I looked at the patient, right, and I thought that why isn't this patient having heart failure despite having increased amount of BNP levels, right? And then I came to know that obesity can affect BNP level, and that can change the diagnostic criteria and all of those things, right? So when you look at the details of these things, when you go into the pathophysiologies and the concepts of these things, then this thing becomes easy. And one more thing that you should keep in your mind is that there are a very limited amount of topics for step 1, step 2, step 3, right? There's very limited topic. The knowledge is not a lot, right? So you can get these things, you can grasp these things, right? If you think that there are a lot of topics and I cannot get into the detail of that, that is not true, right? There are some topics, and all of these topics are very much interconnected, right? ADH is interconnected with the heart failure is interconnected with hyponatremia, they are connected with AMP, BNP, SIADH, which is interconnected with all of these. So try to think that there are very less things and I have to get the maximum amount of grip on these things. So get the maximum amount of grip on these things. Thank you so much, Dr. Y. Thank you so much. Right. So I'll try to bring the best of me to you sites. I'm gonna try to incorporate the basics with everything. Right. So especially the biochemistry, the micro, they are all important, right? Okay, guys. So take care. So this was the lecture for today. We are gonna start tomorrow. We are gonna do the thyroid disorders, right? So if you can study, so if you can give a read to the thyroid disorders before, it's going to be good, right? And then we are going to discuss all of the thyroid disorders and the thyroid cancers as well. We are going to complete that, and after that the next day we are going to focus on the diabetes and the parathyroid disorders, and after that we are going to the pharma. Okay guys, take care, bye bye.
Hey, could everybody like leave this so that the recording could be processed? Because when we stay on it, the recording, it stays long to be uploaded. And they sent a new link in the group for micros. So could everybody please end this Google